Finals SAQ39 Anesthesia in the CCU. You are asked to anesthetize a 75-year-old man for an urgent DC cardioversion on the coronary care unit. He has a broad complex tachycardia of 150 beats per minute, but is maintaining a systolic blood pressure of 70 mmHg and has a GCS of 13/15. A. List the advantages and disadvantages of providing anesthesia in a CCU. Advantages includes no need to transfer unstable patient to another location, minimize delays to treatment, close availability of cardiology specialists, equipment, drugs, and staff. Disadvantages includes remote and unfamiliar environment, possible lack of availability of monitoring, especially capnography, anesthetic drugs and equipment, skilled assistant, adequate recovery care and facilities, competent trainees, consultant supervision, and timely anesthetic support if problems encountered. Potential lack of feasibility of team briefing, WHO checklist, and VTE assessment. B. What factors must be taken into consideration when choosing an anesthetic technique for this patient? This includes period of starvation, risk of reflux and aspiration, anticipated difficult airway, any other investigation results, other medical history. The patient may have limited history as he has a GCS of 13, likelihood of whether this is an isolated broad complex tachycardia or presenting feature of an ischemic myocardial event, post-cardioversion plans, whether there is a need to transfer elsewhere for further management, such as cardiac catheter laboratory, and valid consent. C. What complications may occur as a consequence of the procedure? Anesthetic complications includes the general risk associated with all anesthetics. Issues specific to this situation includes aspiration secondary to full stomach, deterioration in cardiovascular stability, failure to gain important anesthetic history information from the patient due to reduced GCS and urgency of situation, and risk of accidental awareness during general anesthesia. Complications of cardioversion includes arterial embolism causing stroke or cardiac ischemia, asystole, pulseless ventricular tachycardia, ventricular fibrillation, burns, electrical injury to staff, and pulmonary edema. Additional information. Anesthesia for cardioversion. Cardioversions may be elective or emergency. Elective cardioversions are most likely to be performed in a cath lab. Elective cardioversion. Despite coming in from home and therefore being relatively stable, patients often have poor ventricular function that has been worsened by their arrhythmia. Other comorbidities are common. Patients are usually day case and in AF. Check anticoagulant compliance or adequacy of INR. Single synchronized shock is usual, with a maximum of 3. Airway plan. The patient may require definitive airway management for associated transesophageal echocardiography, which is used to check atrial appendage clot. Position head up with face mask and pre-oxygenation. Have a backup airway management plan. Propofol with or without midazolam are usually sufficient for face mask GA. Although cardioversion is very stimulating, it rarely requires opioids afterwards. Atropine may be required for sinus bradycardia post-cardioversion. Placing pads front to back is most effective, especially in the obese, or if previous repeated shocks are required. Consider in situ devices such as permanent pacemakers when placing pads. Prior to anesthesia, check the team is ready and discuss defibrillator safety. Operator may be anyone from cardiology specialist, nurse practitioner, or inexperienced junior doctor. If the patient has an ICD in situ, an electrophysiologist should be present. The device may be used to perform the shock, however battery drainage outweighs the potential risk of damage to the ICD, hence external defibrillation is preferred. Emergency cardioversion. Emergency cardioversions can be for atrial or ventricular arrhythmias and performed anywhere in the hospital depending on urgency. Unstable patients in resuscitation bay will need very little in the way of sedation. Unfasted patients may need RSI if high risk. Even in cases of high urgency, skilled airway assistance for anaesthetists must be available, and all drugs and equipment should be checked. Other details have been discussed in the previous section. Thank you.